All right, so what we're going to talk about today is lumbar spinal stenosis. Lumbar spinal stenosis is basically when the nerves in your spine are compressed. So you can see the spinal cord over here on this MRI. It's this black thing over here. And on either side of it, you have these white marks. That's the cerebrospinal fluid. You want that cerebrospinal fluid because it allows the spinal cord to move around in the spine freely. You can see as we're moving down on this MRI, you have a little bit of a herniation there, a little bulge, but it's really not impinging on the spinal cord, so it's not as much of an issue. But as we go down to this L3-4 level, you can see that it's now pressing, it's compromising the spinal cord. When it starts to compromise the spinal cord, people will start to get symptoms from this level down, which means if it's pressed over here at the L3-4 level, you'll get symptoms in your thigh, you'll get symptoms in your knee, down to your foot, to your big toe. That's the L3, L4, and L5 distribution. So people can have weakness, they can have pain, you can have, we call that radiculopathy. You can have inability to walk for long periods of time. When stenosis gets really bad, you can actually start to lean forward. The reason why people start to lean forward, as we get older, people start to lean forward, the reason is these people have a lot of stenosis. When you have stenosis, the diameter of your spine increases as you lean forward. That's why they lean forward. When you extend your back or when you go backwards, the diameter decreases, and so you're further compromising the space. So traditionally, the approach for this was to do surgery. And with surgery, you take away this bone. We actually look at it in the lateral. This is actually a picture, a cross-section of the spine. You'd actually take away this bone right here, this bone. That's the lamina. That's called a laminectomy. You take away that bone and the spinous process, and you would fuse the spine. By fusing the spine, you'd put rods and screws. I'm going to show you a picture in a second. But you'd put rods and screws up and down the spine. What we want to do is say, okay, we have that approach, but why don't we do something that's a little less invasive, a percutaneous approach? And what we're doing here, there's two options that we have. And I'm using this MRI because it's very telling of the two different devices that we can use. So for this level right here at the L3-4 level, you can see there's a little bit of spondylolisthesis. That's where one vertebral body, this is called the vertebral body, is shifted a little bit. It's not shifted, it's not shifted more than 5 millimeters. It's shifted less than 5 millimeters, so we can use what's called the Vertiflex device. This is a Vertiflex device. We place that in between the spinous processes. So basically we would place that right here, right in between these two spinous processes. And that will increase the space that you have here. See, when we don't have this device in place, as we squeeze the spine, this is what happens because the discs lose water. They dehydrate over time. When the discs lose water, everything squeezes down. What we're doing with the Vertiflex device is we're saying, let's put that guy in here. Let's open up this space. So we would put that over here. If you look at the L4-5 level, you can see there's a lot of spondylolisthesis. Spondylolisthesis is where, again, one vertebral body shifts forward in relation to the next vertebral body. What that does is many things. It creates stenosis right here. It also creates an unstable spine. If you can imagine, if we shift one vertebral body in front of the other, there's a lot of instability. It creates pressure on the nerves, both as the nerve is exiting the spine, as well as in the center of the spine within the spinal cord. It also causes what we call ligamentum flavum hypertrophy. That is depicted over here. You can see there's this little V formation. That's called the ligamentum flavum. The ligamentum flavum can become thick over time and it can actually compress the nerve. So what we do with the Minuteman procedure is we say, okay, we have that spondylolisthesis, we have this vertebral body shifting one in front of the other. Why don't we stabilize that whole thing? That's called the Minuteman procedure. As you can see over here, we put this, looks like almost like a hook that you would hang plants with. But we put that right in between the spinous processes. And what we do is we support the whole spine, so now it can't shift one in front of the other. Stabilizes the spine, but what it also does is it actually lifts, instead of these two spinous processes one against the other, it actually lifts the spinous processes, takes away a lot of the stenosis in the spine centrally, and it takes away a lot of the compression that you have on the nerves laterally as the nerves exit the spine.